The webinar's live.
Thank you. Good afternoon, everybody, and welcome to the meeting of the Clinical Commissioning Group's Primary Care Commissioning Committee. This is the second part of our meeting this afternoon, and thank you for joining us in this very hot weather. This is a meeting that's held in public, and it's not a public meeting, and it's held as a live webinar, so people can keep their microphones off when not speaking, please, and indicate their wish to speak in the chat box, and I'll try and keep up with you. The meeting's also being recorded, so it'll be made available on the Clinical Commissioning Group website following the close of the meeting. We split the agenda into two so we can maximise the relevant attendance at the meeting because the webinars only allow so many people on at one time. It made sense for us to do that. So this afternoon, this part of the meeting, we're going to focus on the application by Danebridge to close its Sandyway branch surgery. So first, I'm going to take apologies. Emma, can you give us the apologies, please?
Have a few apologies. We've got them from Dr. Leslie Appleton, Dr. Paul Bowen, Dr. Sinead Clark, Tracy Cole, Suzanne Horrell, Dr. Andrew McAlevey, Dr. Fiona McGregor-Smith and Denise Smith. In addition, we have apologies from Linda Risk, although she is being represented, her nominated deputy is attending in her place, that's Andrew Whittingham. Carla Sutton, although Sarah Smith is attending on behalf of NHS England and Improvement, and William Greenwood, although Simon Powell is in attendance on behalf of the LMC.
Thank you very much for that. Have we got any other declarations of interest that we need to take into account here? No. Except I would say that Fiona McGregor-Smith is normally a member of this committee and has declared an interest and therefore obviously will not be attending the committee, and that's had nothing to do with the committee process while this procedure has been progressing. Okay. I don't believe we have any public questions, is that right? No? Okay.
That's correct.
Lovely, thank you very much. So I'm going to move on now to the main committee business and do some opening comments if I might. Today we've got several documents in front of the committee, which no doubt all members of the committee have read and have formed questions they wish to ask. I thought it would be helpful, however, to summarise some of the key points of the meeting of the 5th of November, because that was quite a long time ago, when the committee first received the application from Danebridge to close the Sandyway branch surgery. It is my intention that we do not revisit or go over the debate we had at that time, but I would like to remind members of the committee that we received an application in line with the nationally defined process. We were also given additional information at the meeting which amplified that application. We heard about the issues faced by practices, the modernisation of primary care and issues in respect of their buildings and their staffing. We received information from the Patient Participation Group, the Cheshire West and Chester Overview and Scrutiny Committee, the Local Medical Committee, the local MP, and also Health Watch. We also had a presentation from the Save Our Surgery Group, which demonstrated there was some local opposition to the closure. The committee decided that given the information made available to it at the time, it would defer its decision at the application so that additional work would be undertaken by the practice in respect of several areas. So I draw the committee's attention to the letter which was sent to the practice on the 15th of November. It was agreed by the committee and it is at Appendix A in your papers. This outlines the areas of concern that the committee had in respect of the application. And so I've asked the practice and the Save Our Surgery Group, and I'm now asking the committee members to focus on that for today's meeting so we can make our decision today. I will now hopefully hand over to the practice to talk specifically about the areas raised in that letter and how they propose to subsume the additional capacity into the other practice operations, how they see their future delivery model, what their plans are for prescriptions, samples, appointments, medication monitoring and multidisciplinary working. I also expect them to explain why they chose to propose the closure of Sandyway rather than Kingsmead. So thank you to Daimbridge for providing the additional information, which is this Appendix C of your report. And I'm going to hand over now to Dr. Mullen, Dr. Perry and Mandy, providing they've managed to join us. I see Mike has, so over to you.
So I hope you can hear me okay.
And thank you.
So thanks for that, Pam. So yeah, so thank you, Noreen. We've got a slide presentation here. What I'm going to do is very much do my very best to stick to the ask of the committee, which as Pam has just explained again. But before I do that, just a very brief introduction. I'm Dr. Mike Mullen, partner at Daimbridge Medical Centre. Joining us today, we've got Mandy Skelding-Jones, who's our practice manager. Mandy's been part of the application to close the surgery from its inception. And also today, we've got Dr. Dave Perry, one of the senior partners at the practice. The reason for that is that with the engagement sessions, unfortunately, although I planned to be present at them, unfortunately I had to take some unanticipated compassionate leave around that time and was away from the practice for around about 6 weeks. So Dr. Perry willingly stepped in and was present at those meetings, and he's here today just in case there are any questions about anything specific which went on at the engagement sessions, but I'm going to talk you through a summary of the points related to those. I'm going to start off in a moment to talk about why an application to close the Sandyway surgery and why not the Kingsmead surgery. And also then, as I say, talk about the engagement sessions, how participants were invited, how we were advised on that, the process really, and some of the outcomes which came from those engagement sessions. And then I'm going to end with a very brief summary. Making a start, if we can, Noreen, if you could just move on to the next slide, which is why Sandyway, why an application to close the Sandyway surgery. Well, as you can see on the slide, I'm not going to read through that, and it's much of what is in the written report. But just to go through some of the important features, I think it falls into probably 4 main areas, and there being the building itself, the rooms, issues around lone working, or perhaps a better phrase would be working in isolation as a clinician, and also future-proofing and development of services in line with, the PCN and integrated care pathways. And so just to take some of those points in a bit more detail, the building is an old building. It does need a lot of work doing to it to make it more fit for purpose. We've had estimates, as you're aware, of around about £300,000 work which would be needed, would be improving the size of the rooms. The rooms are small. In terms of the numbers, we've got 3 GP rooms there. One is very small, and we've also got a treatment room there, which is also is quite tiny. And the difficulties that creates, of course, is with patients being seen in the rooms, with carers, which they often come along with, parents of children, pushchairs, wheelchairs, etc. So the small rooms are difficult. There's also the issue of the couches. We use modern, up-to-date couches, examination couches at Kingsmead and Daimbridge. They're essential really for modern practice, and the rooms are not large enough to fit them in. These couches are, I'm sure you'll have seen them, they go up and down, but also they move away from the wall, which can be an essential part of certain examinations, gynecology or orthopedic examinations. So the size of the room is an issue, and the rooms are not, as I've explained before, are not soundproofed. And the building itself, although it does have disabled access, there's poor access into the rooms and into the toilets for disabled and patients. Wheelchair access particularly is difficult. In terms of the building itself, well, making the structural changes to the rooms would be important, would be costly, but also there's a health and safety risk at the practice in terms of patients and staff. It needs an up-to-date fire system, safety system, which would include new fire alarm, would include new wiring, would include safety lighting, and also a new fire exit. And we would want to rewire the building totally. It's got old wiring in there, which wouldn't be up to modern standards. As we all know, once you start to pull apart at things and get surveys, there's likely to be other things which would crop up. I'm not aware that we've had a survey or an assessment of the roof, but that would perhaps need looking at as well. All of which we believe will be very costly from the estimates we've received and wouldn't be value for money in our opinion, nor that the opinion of the LMC for NHS England, or indeed the taxpayers. The other issue is what has been termed lone working. It's more about, although lone working can be an issue in a small practice, usually there isn't just one person in a practice, but it has happened at Sandyway because there's less people working there. You're more likely at some point to find yourself on your own, perhaps as a receptionist early on in the morning, or as a clinician when the receptionist has left and you're on your own. But it's more about an issue of clinicians working in isolation. And what I mean by that is junior clinicians, junior GPs, very much are used to working with a senior colleague, at least one senior colleague. And that's important for them because, you know, a second pair of eyes actually physically there in the practice is important to look at a patient or look at an ECG. As I recall, I think Dr. Andy McAlvey made mention of that at the last the meeting back in prior to the one in November, and I think he's quite right. It can't really be done over the telephone. The problem we have with the Sandyway surgery is it's not just Sandyway, it's the fact that we have 3 sites. So then we have difficulty staffing all the sites with enough clinicians to put 2 clinicians, a junior and a senior, in the surgery at Sandyway to afford that extra support that the junior doctor needs. And it isn't enough to have an MSK practitioner or a practice nurse or indeed a pharmacist there. The doctor wants another doctor because, of course, the skills and the knowledge is with another doctor. And it's true of nurses as well. Practice nurse wouldn't have come to ask me about a nursing issue in terms of wound management. I am, you know, I'm afraid to say pretty clueless on that. But she would want to speak to another nurse, and there just isn't the capacity in terms of enough people in clinicians working within the organisation to staff all the sites appropriately. And then I think the final point about the Sandyway surgery, which is an important one, is future proofing. It's about, you know, developments in terms of the primary care networks, integrated care pathways, where investment should take place to allow for future services to be delivered. And certainly Dainbridge Medical Practice wants to be very much involved with the future developments in primary care. And indeed, of course, we are to some degree already. But it is our opinion and also that opinion of the LMC, that Sandyway surgery doesn't lend itself to new services being offered from that site. And I think that is probably true even if there was a large investment in that site. It just isn't positioned well, and it just isn't big enough. So that's the reasons why Sandyway. Noreen, could I ask you just to move on to the next slide, please? So in many ways, it's all the counterpoints really. Why not Kingsmead? Well, you know, if we were to describe Kingsmead, it is a purpose-built building. It's new, it's modern, it's easy to clean. There are 4 large GP consultation rooms which allow for the couches I've described. And also we've got 2 large practice nurse rooms there. We have a multifunction room. The multifunction room is an essential facility really. It allows for anticoagulation clinic to run from there. So these are services which are not necessarily delivered by us at the practice, and other services come into the building. Historically, health visitors have run clinics from that room, anticoagulation as I've mentioned. But also we have an upstairs which is accessed by stairs and a modern lift, and that allows for a pretty much state-of-the-art minor ops suite there, from which we have offered minor ops to our patients and others in the town. and also vasectomy services run from there. Upstairs in that building, we have a whole host of admin spaces, which, again, thinking about future developments, some of those I'm sure we've discussed many times, the practice could be developed into clinical spaces. So very much future ready Kingsmead surgery. There isn't the issue of isolated working at Kingsmead. We invariably have a number of staff working there. The other issue with working in isolation is if there's an emergency, and at Sandyway, it is very difficult if you've just got one clinician or two clinicians. If somebody collapses, it causes absolute chaos in any practice, even at Dambridge it does, and at Kingsmead. But if you've got more personnel there, you're likely to have a better outcome. It's much less stressful for everybody, not least the patient. And also the difficulties we have at Sandyway is what to do with the sick patient. There's not really anywhere to put them whilst we're waiting for the ambulance to come and collect them, and we have had that issue. And it's true to say that North West Ambulance, with the best will in the world, don't come to practices very quickly to collect our patients. Even if they are quite sick, they're seen as low risk. And we have waited hours. I've waited for 4 or 5 hours for patients of mine to be collected by an ambulance. And facilities at Kingsmead allow for that. We have a multifunction room, we have clinical rooms. We can sit patients in quite safely to be monitored. One point really, I guess, about Kingsmead site is, of course, we have run the COVID immunisation clinics from there, which are not just for our patients, of course, but for those for the rest of the town. I think that's proof that that site is very amenable to doing different things from. Wouldn't have been appropriate to do that at the Sandyway surgery, for example. So thank you, Noreen. Would you just move on for me? That's quite a busy slide, but I think it's an important one. So moving on to the engagement sessions. So I think the important points here are that we were very much led by, and expertly led by the head of communications at the CCG in terms of how to run the sessions, how they should be delivered, who should be invited, how people should be invited. Obviously, this is new territory for us. We're not experts in this, so we're very much led by the experts and did pretty much everything which was suggested to us. And some of those points, of course, well, all of those points are in the written report which has been submitted, and on the slide you can see. Important points on there, I think, is that all patients who were registered who registered an interest at the initial focus group in February 2020 were invited. PPG members were invited, and they were allowed to extend further invitations. Email invitations were sent to the Resident Action Group members. Health Watch were also involved, extending further invitations. The CCG worked with the practice to identify key stakeholders. For example, local parish councillors were invited. The sessions themselves were facilitated by a CCG, senior CCG member, and they were very much listening exercises. And after each session, there was an outcome published, created by the CCG and published by the CCG for those who were in attendance and not to look at. And I will come to some of those outcomes in a little bit of detail in a moment. Other points to raise, I think, are the duration of the meetings. Again, that was in discussion with the CCG, and they were around about an hour and a quarter. Planned for, in fact, many of them ran over, bar one, I think. The platform we used was Microsoft Teams. Again, this decision was made in conjunction and discussion with the CCG. But the reason for that was that, of course, the other common platform, popular platform, is Zoom. That isn't supported by CCU across the network for Midlands and Lancs, so wasn't an option for us. And that really, the basis of that is because Zoom is seen as a security risk, I understand, although confidential issues were not discussed at the meeting. So that wasn't the reason, but we were very much led by the experts on that. Outcome summaries were created, and as I say, I'll come to that in a second. And I'll talk a little bit about what we've been able to say that we can do, and a little bit about what we think we can't do based on the comments and the feedback we received at the engagement sessions. So Noreen, could you just move on to the next slide, please? So I'm going to go through each of the sessions in some detail, just to pick out really what I think, or we think, are important points. Engagement session 1, well, this was about prescribing a medication. We know that medication is a big risk for patients, often the interface between primary and secondary care. There's problems often there with prescribing. But in primary care, it's a lot to do with acute prescriptions and repeat prescriptions. And undoubtedly and understandably, I think this has caused a lot of concerns for patients, particularly the elderly and the vulnerable in Sandy Way, which we all at the practice understand. So we've gone a long way, I think, to try and find solutions which are already in place, many of them, to mitigate the risks associated with that. So I'll quickly talk through some of those, if I may. I think these are important points. The first one being repeat dispensing. So some of you will be familiar with that. However, for those that aren't, it is basically the process of allowing the pharmacist to have 6 months worth of prescriptions all at once for a patient, which means that patients don't need to keep requesting repeat prescriptions each month, and go, albeit changes to prescriptions can sometimes cause problems, but in the main it works quite well. Many of our patients are already on repeat dispensing systems, and we would very much, if the application to close the surgery was successful, we would very much want to be targeting through our pharmacy team those patients who we feel and they feel would benefit from repeat dispensing to minimize the necessity to ask for repeat prescriptions each month. DMARDs, they are disease-modifying anti-rheumatoid drugs. So these are drugs, the immunosuppressant drugs, which need very close monitoring with blood tests. Historically, across all practices, we've used what we call a blue booklet system, which is a hard bit of a paper booklet, which always needed to be handed in at the surgery for safety reasons. The results of the blood test were written in it. The doctor would read that and then produce the prescription on request each month. That would have meant that patients, and does mean that patients, actually physically need to come into the practice. Needless to say, of course, that would be unacceptable if the application was successful. And in fact, prior to the application, we'd already been starting making moves to move away from the blue booklet system. And now there is no blue booklet system. It's still a safe system we use, and the blood tests are easily accessible now on the computers that we use, and there's no need for the DMARD population to be bringing in the buckets to the surgery. I think we have probably over 100, 120, 130 or more patients on DMARDs. We're fortunate at Daybridge, we do have 2 quite senior community pharmacists that work with us, along with a pharmacist technician. We have made great efforts to develop a close working relationship with the community pharmacy in Sandy Way Rowlands, spearheaded mainly by Claire Davis, our pharmacist. And that's important really because we know that one size doesn't fit all, and there are always problems day to day with the repeat prescriptions. The more elderly, more vulnerable patients are more prone to suffer these problems, and having a pharmacy team can really help with issues like that on a personal level, alongside our prescribing team at the practice, which is made up of non-clinicians. But we would be very much focusing on patients in Sandy Way who were recognised to be more vulnerable, in terms of their prescribing through our pharmacy team, as much as the doctors and nurses, to try and make things as low risk as possible. One example of that is through the medicines management team, practices across Cheshire have always been encouraged to have monthly prescribing, and for patients to request their prescriptions from the practice, not the pharmacist, in order to reduce waste. Pharmacists were found in many cases to be over issuing medication, which was wasteful. Now that for many is absolutely fine, and it's something that we have held up very much at Daybridge Medical Centre medical practice over probably 10 or 15 years, since the days of Mark Dickinson working with us. But it doesn't work for everybody, and it can cause problems for some patients who just cannot get the request into the practice. And we would work through our pharmacy team to have a more bespoke approach to them, such that they could request their medication through the pharmacy. And the repeat dispensing system, of course, would also allow for reduced risk there. EPS, I'm sure many of you are familiar with, electronic prescribing, allows for exactly that, prescriptions not to be given out as a piece of paper into somebody's hand, and it works perfectly well with remote consultations, which I'll come on to a little bit later, in terms of acute prescriptions being prescribed directly to the pharmacist locally, rather than patients having to come to the practice for them who haven't been seen face to face. We'd always encourage our patients to use new technologies, such as ordering and requesting medication through the website. We are aware that there are difficulties for more vulnerable patients in doing that. And again, as I said, our pharmacy team and prescribing team would be looking out for those patients. And we do that already, but it's all about trying to not have a one-size-fits-all. But if we have general approaches which work for most, it allows us to be safer, more efficient and consistent, offer more consistent service. So I think that's it really in terms of session one. So I think that was a good, productive session, certainly. Could I ask you, Noreen, to session two? So this was just as interesting. There were 5 attendees at the first session, 5 attendees at this session. Undoubtedly, this was a bit more difficult, and samples, something that we have struggled with. I'm sure many practices are similar, but sample production and process is a problem for all practices, and certainly is going to present problems, I think, with if there were a successful closure, a successful application to close Sandy Way. But we have done our very best at the practice. We've listened to concerns of patients, and we have looked at what we believe is a safe, efficient, consistent way of dealing with samples. The only way around this, really, and we're talking in the absolute main urine samples, you may be surprised to hear we have approximately 100 to 150 urine samples brought into the whole practice, into Dainbridge Medical Centre, for the whole of the population on a weekly basis. Needless to say, that we have noticed since the pandemic, there have been problems with that. As you might imagine, that number of samples coming into a practice, you need to have a robust protocol. We've had a number of significant events with samples since the pandemic, which we have treated seriously and looked at our process very carefully. We now have a much more robust and safe service and system and protocol for handling samples, but it has to be housed at Dainbridge Medical Centre. We can't accept samples even at the Kingsmead surgery because it just creates problems and errors, which of course can be very serious sometimes. In terms of getting samples to the surgery, well, there were suggestions brought up at the engagement session, which we feel we would struggle to deliver. So we can't have samples being dropped off locally at any sites really in Sandy Way. They really would need to come to Dainbridge Medical Practice. The reason for that really is twofold. For example, at the pharmacy or other local sites, the reason for that is twofold, as you can see on the slide: data protection and infection control. Infection control is a big risk in practices, and these samples are dealt with very carefully when they come into the practice, and it would be inappropriate for them to be going to other sites. And data protection, of course, patients' data is all over these samples in terms of the labelling, and it's our importance as guardians of our patients' data to be mindful of that. In terms of just a couple of examples where we again try not to have a one-size-fit. I'm awfully sorry that the lights in my office have just slightly dimmed. I don't know there's a problem with them. I'm spending so much time in here these days, it's burning the system out, I think. But a couple of brief anecdotes. We have, there was a patient who, one of the outcomes engagement sessions in some of the feedback, a patient, what I assume to be an elderly patient, had mentioned that she'd had urinary tract infection symptoms. She'd contacted the practice and was asked to deliver a sample. She was unable to do this. She had no transport, etc. And as a result, in fact, wasn't treated with an antibiotic in a timely fashion and became more unwell as a result. Well, that is something which obviously is a risk, and that is not something that we would want to happen at the practice. It is about having a more bespoke approach or a pragmatic approach to when the system isn't working for an individual. So, for example, we would want a patient like that to be passed from the reception team to a clinician so that the clinician then can make a sensible clinical decision. In fact, we had a significant event analysis around that event. And in fact, that did lead to some retraining, and we are constantly training and retraining our staff, both clinical and non-clinical. But the point I'm making is the systems we have don't suit everybody all the time. And although we do need systems so that things run efficiently for most, we need to be flexible around them at times. And that's very much what the ethos of the practice and very much what we would expect our staff to be doing in an example like that. There is another example. We have a paramedic who works with us now as an employee of ours. And there was an incident recently, in fact, she's going out to visit this patient today, where there was a request from the Christie Hospital for urine sample and blood sample, etc., and blood pressure. Because she isn't completely housebound, understandably, the community nursing team declined to visit her. Our paramedic has gone out there to collect the sample from her and to do the other bits and pieces. So we're always looking for solutions for those individuals where it's not working. And I do believe that they are not common, but we need to be mindful of them and not disadvantage patients like this who have difficulty with accessing transport, etc. So that is it really in terms of engagement session 2. If I just go on to Noreen, the next session, the next slide, please. Thank you. So this was about appointment booking. There was an ask of the committee to explain how we would subsume appointments at the other, how we would deal with the loss of appointments at the Sandyway surgery if the application was successful. I think a really important point to make is there won't be any less staff, no less clinicians working if the application was successful. So by definition, there will be no less appointments. They will just be run from the 2 other sites. I think one of the most important things to understand here is how the appointment system has changed with our new model of working within the practice, in fact, across all practices in general in primary care. It's a triage first approach, which essentially is everybody has a telephone consultation first, and then if necessary, invited to the practice for a face-to-face consultation. Patients we tend to invite down are those who are unwell, those who are having difficulty on the telephone communicating, those who perhaps have had a number of telephone calls already for the same issue need to be brought down, and also those patients who request a face-to-face appointment. And the government, NHS England, are very much expecting patients, if that is their request and that's their desire, they should be offered that, and that's very much our ethos and approach at the practice. We are probably seeing approximately, I would guess, 1/4 to 1/3 of patients face-to-face following a triage first appointment, telephone appointment. This isn't a new concept. Other practices have been using triage first for many years, indeed local practices in Winsford and Northwich. And in fact, Danebridge, we did try it around about 15 years ago, but it failed because we didn't have the technology to make it work. But it does work really well now. The technology being text messages, photographs come from mobile phones, video consultations, email consultations. And what this allows for, which is a really important point, I think, for the issue around Sandyway, is that it opens up flexibility within the appointment system. So for example, the system of triage first actually does work for the majority of patients, but it doesn't work for everybody. And for example, an elderly vulnerable patient, let's say in Sandyway, who had a triage first call, who needed to be seen face-to-face for the reasons I've explained, the flexibility around the appointment time we can offer is massive compared with what it was pre-triage first. For example, if I'm taking a call in the morning, I may only be seeing 2 or 3, 4 patients face-to-face, which allows for enormous flexibility when that patient can come down to the surgery. elderly patients often don't have transport. In my experience, often they can find transport from a friend or a relative in most cases. And that friend or relative may not be there immediately. So I can say, well, you can come down this afternoon, give them a time. It doesn't matter because we're not constrained by a rigid appointment system anymore. And these changes and innovations, we would very much want, not just at Daybridge, but across the whole of primary care, to want to continue in some format going forward. So this is not just restricted to the pandemic times. I think that is a really important point. And needless to say, the other issue is, of course, if we had a patient who is too sick to travel, then we'll offer a home visit. We offer home visits. We have a paramedic who does home visits. We have work from the in the community of two clinicians who go out to rapid access, rapid response nurses. I'm awfully sorry. I've just been distracted by my screen going off. Let me just put my password back in. Sorry, thank you. So we will visit patients who not necessarily just the housebound. It is generally the housebound, truly housebound, who we will visit. But if somebody's too ill to come to the surgery, we will visit them, of course, if they're unable to get to the surgery. Excuse me. Okay. There were a few comments from that session which are important, I think, around appropriate numbers of appointments. Well, we're constantly recruiting to improve our appointments at the practice. I did explain a little bit about recruitment and retention problems at the last meeting. We have a whole variety of diversity of appointments now, MSK, physiotherapy appointments, counsellors, practice nurse clinician appointments, and pharmacy telephone appointments. And with time, hopefully, we will also have some psychological therapies appointments as well. But this is on the backdrop very much of a recruitment drive to bring new GPs into the practice and practice nurses. I said last time, and I won't go on about it a great deal here, but recruitment and retention is a massive issue in primary care. And doctors, GPs, salaried doctors who are employees of ours, it is very much a seller's market. And if these doctors are not happy in the environment they're working in, for example, isolated working in an environment, they will leave, and they have left. I'll talk a little bit in a few moments, a little bit about finances. You may be surprised to hear that Daybridge Medical Practice has spent just over £56,000 on agency fees alone for new salaried doctors. That isn't their salary, that's just recruiting. Some of those have left. We recoup some of those agency fees, but others, that's an additional cost. But that's an investment which is important to us because it improves the service that we offer for all. There was mention of parking. There is, theoretically and in practice to an extent, there is less need for parking at Daybridge Medical Centre now because we're seeing less patients there, but parking is definitely an issue there. I don't think it is something that we will be able to change, I'm afraid. There was a request from the feedback that telephone appointments continue as they have been doing through COVID. That was very positive. A participant said they'd found the GP app very useful. One response was appointment booking was difficult and intimidating. And again, I think for vulnerable patients, booking an appointment with a new system can be difficult. And again, I think that's where we have to be training and retraining our staff to make sure that the more vulnerable patients don't fall through the cracks in the system moving forwards if the application were successful. With the IT, in my experience, although it's not the case in every case, of course, but friends and family do facilitate telephone calls, text messages, etc. To say elderly patients generally are IT illiterate obviously is an insult, but many do struggle with the new formats, but often are helped by friends and family, and we're also here to help them with that. But we don't have a one-size-fits-all, and certain formats don't work for some patients, and we very much are aware of that and would want to watch out for those patients and be mindful of the risks that can pose. Things from that session which we can't do, there was mentioned of impact of transport. It's beyond our gift, as has been mentioned before, and indeed by the LMC. for us to have any impact on the local transport infrastructure, although we do understand that and very much are mindful when we're having consultations on the telephone about transport issues for those that don't have their own transport. We can't offer clinical consultations in non-clinical environments. There was suggestion of using the village hall or local library, etc. Again, I can understand that suggestion, but it is not something that we could entertain for many of the reasons that why Sandway surgery isn't appropriate, we feel. So yeah, I guess that's that engagement session. Noreen, would you just go on to the last session for me, the next slide, which was session 4. So there were much more attendees at this session. This was 19 attendees held on the 22nd of April. This was led by Dr. Chris Richardson, who is a GP, and was very much giving a flavour of the future of the primary care networks, integrated care pathway, to kind of deliver information to those attendees to understand, if you like, the bigger nature of the changes in primary care across the whole of the nation and across affecting all of our patients in Northwich and at Dainbridge Medical Practice. In terms of what's important for us at Dainbridge is we want to embrace the future. We are embracing things at the moment. Of course, the COVID vaccination site was run at Kingsmead, but the future innovations from the primary care network, which we're very much a part of, with one of the directors being a partner at the practice, is something that we want to be involved in, something that we want to shape for the good of our patients and the residents of the whole of Northwich. In order to do that, we really need to have sites which are appropriate and fit for purpose. In our opinion, Sandway surgery isn't in that regard. The future sometimes is a little bit difficult to predict, but the general direction of travel is more services from hospital being delivered in the community from sites like ours, all for the good of patients, of course.
Mike,
Dr.
I'm just conscious of the time.
Okay, yeah, I'm pretty much done. Yeah, okay, thanks, Pam. I'll just summarise then, thank you. So in summary, just a very briefly, key issues. I think that we have answered all the questions which were posed to us by the committee. We've engaged with the residents, we've listened, we've created outcomes which we have responded to, and I explained some of the changes we've made. There is mention, again, about the future-proof, and we want to be engaged in services which are delivered in the future. This certainly is not a cost-cutting exercise for the practice, and it hasn't been precipitated by the retirement of senior partners at the practice. They've been very much in planning for years in advance. But it is about avoiding instability of finances within a practice, within a business, which we believe very much big investment in Sandway surgery would cause. So that's it, Pam. Thank you. I'm sorry I've taken so long, but thank you for listening.
Thank you. Okay, thanks for that. I'm proposing to go to John for Save Our Surgery Group for their comments on what we've heard, and then I'll take questions after that. Welcome, John. It's nice to see you again. Thank you for taking time to come and speak to the committee. Over to you.
Thanks, Pam. Thanks for the opportunity. I think today I'm here really to speak for the patients, and I know that was almost a given, but I think it needs emphasising that that's an important part of what Save Our Surgery has been about. But I was asked to consider the report submitted by Dainbridge, so I'll start there and talk a little bit about that. I was a little bit concerned about the number of factual errors in the introduction, which started me wondering about whether anybody at Dainbridge had even read their own report before it came out. And factually, the first paragraph is completely wrong on dates all the way through. But moving on from that, talking about the choice between Sandway and Kingsmead, in the report, Dainbridge say that no formal site survey has been carried out, yet they are actually able to say that they've got an estimated cost of £300,000. Now, Dr. Mullin has suggested there's more work being done there, but that hasn't been shared widely with the patients. The patients are only aware of what they are being told by Dainbridge at any time. We're being told it's not fit for purpose, and Dr. Mullins talked a lot about that. CQC declared Sandyway fit for purpose. That was something that public were able to read and see, and left the patients wondering, well, if Sandyway is fit for purpose, why does it have to be closed? We've talked about in the past, and Dr. Mullins has talked about lone working clinicians not being able to work in teams. But our patients would say, well, that's really a choice that Dainbridge have taken. They've decided to only put one GP down there with the receptionist. There are 3 GP rooms, yes, not up to the state of the art at some of the other surgery rooms, but they could put more doctors there if they wanted. They talked about the, and Dr. Mullins talked a lot about the engagement sessions that were requested by the PCCC. There were other issues that were asked to consider, which not in the notes of the PCC outcome, the engagement outcomes, or any recollection of people who were at them. Topics that were not discussed that were the use of community rooms, although Dr. Mullins has quickly referred to it a few minutes ago and saying that's not suitable. That wasn't a topic that was run through and minuted in the discussion, but it was something that PCC had requested last November. Similarly, the liaison with multidisciplinary teams to specifically look at the issues of Sandyway and Cuddington patients. That was something, again, that this committee did ask them to do. Now, those questions were raised in the engagement sessions, but were not answered and were ignored in the outputs. So patients didn't feel that the engagement sessions gave them a fair shake of the stick when they looked back at what questions were in their inputs and what the outputs were from those sessions. They say, Dainbridge is saying that in their report that the feedback from sessions 3 and 4 were less constructive than the others. Session 3 was about appointments, and the output from the session, if you look at it, is not relevant to the questions posed or even to the title of the session. So we wonder what came of what went on in that discussion, because there's nothing about appointments in the outputs if you look at that report. And session 4 was about the future care model, and the ICP, Dr. Richardson, did paint a bright picture of something that really isn't up and running yet, and it's unproven, and it will not be up and running for some time from our estimate of things. So don't close down our surgery before the new model is in place, is where the patients are coming from. There's a section called implication for the practice of keeping the Sandyway open. Section 2.4 in the Dainbridge report. Edward Timpson MP actually wrote to the practice recently, and they wrote back to him and in specific areas talked about management of the practice. They claim that the decision, and Dr. Mullins has repeated that, the decision to sell off Sandyway is purely coincidental with the imminent departure of 2 partners, one of whom we know became an owner of Sandyway in 2014. So has provision been made for partner retirements, or do they need to sell? Dr. Mullins reassures us there that they don't need to sell to allow the partners to retire. Patients, frankly, don't believe that. They also list in the letter to Edward Timpson a number of structural challenges in the Sandyway building. Again, Dr. Mullins has referred to those. But they talk about windows that are so rotten they have to be replaced. So there's no provision ever been made for maintenance of the building. They also report that they rely very heavily on locum doctors. I think this is an important point. Dr. Mullins has talked very long and in depth about the importance of the patient and giving them the right care and the proper team working together. In the letter to Mr. Timpson MP, they say, we currently rely heavily on locum doctors. This reduces continuity of care and increases the cost to the NHS, as locums inevitably order more investigations and make more referrals to secondary care. So the question in patients' minds is, Well, how will any new model of care work if the reliance is on locums who divert patients to secondary care anyway? Also in the letter, they talk about the number of clinicians working in the practice, but they say in the letter, Deirdre is saying, only one of these clinicians is working full time. And this GP partner is soon to reduce their commitment to the practice, which means they've got an equivalent of 10 full-time equivalent GPs in the practice. But there are 19 GPs named on the DMP website. So what they're telling us is that senior clinicians in the practice only attend for 50% of the time. So is this why Damebridge ranks only 6th in terms of patient satisfaction out of the 7 local practices in the primary care network? You'll be well aware of the National GP Survey that's just been published. And how will continuity of care be ensured if the reliance is on locums and the GPs are only in attendance 50% of the time? In the letter also, they say there's no evidence that our patients have suffered any adverse outcomes in terms of their health due to the restricted service at Sandyway. How can they possibly know at this stage? We're still in the pandemic. The NHS is just recovering back to normality. They also talk about there's another NHS GP surgery situated 1.7 miles from Sandyway, and should the application to close be successful, then patients can express their choice and register with that practice if they wish. 1.7 miles may be as the crow flies, but it is 2 bus rides away, and it's also the worst performing surgery in the primary care network by a long way, according to the National GP Survey. So we, as patients, wonder how can this throwaway suggestion really be made with patient care in mind? Patients feel they've been treated with contempt with the minimum effort made to talk to them in the initial consultation. That view was endorsed, you remember, by Quack Scrutiny Committee. They felt they'd been fobbed off with issues such as blaming Sandyway for the downgrading by the CQC. This turned out to be far from the true situation. And to quote a patient today, the message we received today, Damebridge are not showing empathy or care towards the patients they have here in Sandyway. So patients are asking that the CCG considers their duty to provide primary care close to home for the Sandyway patients. Thank you.
Thank you, John. Thank you for that very succinct information that you've given us. You made reference in that to a letter from the MP, Edward Timpson, and there's a letter actually as part of the bundle that people have received as a Appendix H. But I think everybody will probably have seen that already. Before I open the discussion up, I'm just going to read something that I've had from the patient participation group. You remember last time they sent us a statement, and they've done that again today. They've put, we've been kept informed and involved in the process of engagement at our monthly meetings, and the patient participation group members participated in the focus groups. We have discussed and debated the outcomes and options for the provision of a high quality service to Sandyway patients. We did not arrive at a consensus on the best and most sustainable way to provide an integrated service which promotes and protects all the practice's patients. So that's the statement that I've had from the patient participation group. Okay, I'm proposing now to open this up for debate and for any questions that people might have. So I've got a request from Wendy in the chat box. Wendy.
Thanks, and thanks John and Mike. That was really well presented, so thank you for that. It does help. A point that John made just towards the latter part was that he felt that patient care was not quite clear whether or not it had any adverse impact on patients in Sandyway because of COVID. Have Damebridge actually looked at any and what effect that actually the closure at Sandyway may have had on the patients? Have there been a lot of adverse impacts or problems that have arisen for Sandyway residents during the last 18 months.
Thank you, Wendy. I'll thank you for the question. I'll take that one, and Dave may want to elaborate a little if he wishes. Hasn't been brought to our attention any adverse events as a result of closing the Sandy Way surgery. One might argue, well, that's a fairly subjective remark to make, but within the organisation, we do take feedback very seriously. We have obviously a pretty robust complaint system and a significant event analysis system, which we run on a weekly basis. So any adverse events which do happen are recorded and discussed on a weekly basis. In terms of the closure of or during the pandemic when Sandy Way surgery has been closed, I run the significant event analysis meeting. I haven't got the details right to my fingertips here, but I am pretty sure, and Dave will correct me if I'm wrong, please, and Mandy, I'm not aware of any significant events which were discussed relating specifically to when the Sandy Way surgery was closed. No.
Answer your question, Wendy, yes?
Yes, I think it is quite an important one, because if residents feel that they have in some way have less of a service because of the closure of that, it's quite important that we know about that. But if you're saying that you haven't actually noted anything of major impact on residents' health and well-being during the closure of that surgery, thank you.
Neil, you want to ask a question?
Yes. One of the sessions was about appointments, and I know John's just made some comments about it. One of the things I'd looked at most recently, probably since the papers went out, was the annual patient survey. And there was a number of areas within that where Danebridge's scores were below the national or CCG average. I would point out there were some that Danebridge was above the national average. And I guess I was interested on, clearly one of the concerns that patients are expressing is the difficulty making an appointment, and that's not specific to Sandy Way, it's clearly broader than that. But you did reference some work that had been going on around looking at how you could improve your appointment booking processes, and you talked about total triage, Mike, and how that's helped with some of the flexibility. I guess I was interested in how we can get some assurance that the work you're doing will leave patients who are probably concerned about appointment booking in a position where they can be more confident going forward.
Okay, thanks, Neil. I guess it's really about collecting evidence that you know, patient satisfaction questionnaires are a useful tool, and it's a good way of assessing how a service is working. We do run a number of different ways of assessing our patient satisfaction. Practice at GPs tend to do it through their own appraisal, but we also do look at some of the details with the help of the PPG about satisfaction of patients. It's difficult, you know. I can sit here and talk very subjectively, but I think to answer your question in a sensible way, Neil, I think reassurance would certainly be gained from feedback from our patients about how the system is currently working. Now, I have a lot of anecdotal feedback, I'm sure Dave does as well, and the other GPs at the meeting, that patients like total triage in the main, but it doesn't work for everybody. But certainly, you know, we could certainly look at to see what satisfaction, what feedback we could have, and we would be very happy, I'm sure, to ask patients and have an anonymous feedback run through the practice. You may say, well, that's already been done with the patient satisfaction questionnaire, but it is about having the right numbers, and the statistics which are published are often, with a big practice like ours, based on very small numbers, and one would question the clinical significance or the statistical significance of those. But that would be one way of doing that. I can't really think of any other way of reassuring you without giving evidence that what's working is working. from a patient's perspective, I don't know, Dave, if you have any other thoughts than that, from your experience, how we could reassure the committee that total triage is actually working at the minute, other than what patients tell us.
Yeah, I mean, I think from my perspective, certainly as Mike says, the questions that were sent out relatively were sent out to a very small, or were answered by a very small pool of our patients. So if you were trying to submit those figures to an academic journal, for instance, they would probably question those figures and say, well, actually, that's only from 2% of your population or even less. Then they are not statistically significant. And those figures, when we read them, are like a dagger through our hearts, because we feel really upset. We work incredibly hard to try and provide as much patient satisfaction as we possibly can do, and that's again not something that's measurable, but we try very hard to accommodate our patients as much as we can. Certainly, as Mike says, we are with the telephone triage system that exists now, it's very easy to react to some people, and because of the nature of what I tend to offer as a clinician, very often surgical opinions about skin lesions and so on, sometimes they're very hard to give an opinion via a photograph or a video. So I can say, well, do you want to come down at midday, 12:30, 1 o'clock? And I'll see patients very quickly, and try and be receptive to the patient's needs. Whereas if you've got a full surgery booked of 16 patients in the morning, 16 patients booked in the afternoon, and then suddenly you get a phone call for someone who wants to be seen, and you think, yeah, I need to see this person. Well, actually, squeezing them in is very difficult, and you might say, okay, you can come at the end of my surgery, no problems at all, 6:15, 6:30 or something like that, and my surgery runs over, which inevitably it does, so you end up seeing them at 7 o'clock. Whereas with this system now, we can be much more targeted to patients' needs, and try and accommodate them as best as we possibly can. I think we work with a big population pool as general practitioners, and it's very hard sometimes to be reactive to their needs, but this system does allow that. It's not perfect, but it does certainly accommodate a lot of our patients' needs.
Thanks for that. Neil, you wanted to come back on that?
Yeah, thanks for that, both of you. And I wasn't intending to be critical. I was focusing very much on the actions being taken. The particular one, I guess, I was interested in with the Sandyway context in my mind was one of the indicators getting through on the phone. Now, clearly, what I was looking for was, are you taking particular actions which will help with that? Because thinking of one of the perceptions of Sandyway will be, at the moment, I can walk down to the surgery and stand at the reception, or pre-COVID, I can walk down to the surgery and stand by the reception, and I know I can speak to someone, whereas when there's no surgery, or if there's no surgery in Sandyway, that wouldn't be possible. So phone will increasingly, along with some of the online tools, be necessary. So I guess that to target my question a bit more, is more that how would we reassure the residents of Sandyway that they wouldn't effectively be ringing a dialing out tone, and feel that they were a bit exposed by that? So hopefully that helps target my question a bit better.
Yeah, again, in terms of phone calls, they are pre-booked, a lot of them, rather than just book on the day. They can be booked in advance, and they may be booked in at 11 o'clock, but that means nothing. It could be a phone call that happens at 10 to 2, or in the afternoon, or 10 o'clock in the morning, as best we can, but we'll certainly try and do them quickly. Obviously, other bolt-on mechanisms are the email consultations, which provide extra access, and then we also still run an emergency telephone system, which is run by nurses and doctors to mop up the inevitable excess of demand. So I think there are many methods of getting in, and you know, I think that is a good system to try and provide availability to our patients.
I'll just add to that, Neil, if I may. So in terms of if the application was successful, the telephone system isn't going to change from what it always has been. So actually what happens is when patients are calling through, they are actually going through a ring, as it were. Mandy will perhaps explain it better than I, but actually it rings through for all sites on the same telephone network. So it's actually, those calls are not specifically coming into Sandyway. They will be taken up by other workers at all 3 sites currently. So in fact, the number of lines and the number of people manning the lines or personnel, the correct term should be, answering the calls coming through, will not change. We do have the ability within the practice to chop and change how many people are working on the telephone. So at busy times, all the lines are open for all the staff. So all receptionists, all secretaries will be taking calls. So we have that adaptability built into the system. We have got a relatively new telephone system now, which allows for a queuing system. Now, we all hate queuing systems, but much better that than getting through to the wrong person or indeed being cut off inappropriately. So that system is in there. And we're also introducing, just as an aside, recording of patients calling into the surgery, so that we've got a record of what's been discussed. And that would also inform if there were complaints or there was feedback, good or bad. We could then go back to see, well, what exactly, because often there can be a complaint, well, the receptionist said this to me and that isn't right or isn't fair. And sometimes it isn't right, and maybe sometimes it isn't fair. But in order for us to learn and train and retrain our staff, recording of consultations, telephone consultations, is a good thing. But it's not going to change, in other words, and we can adapt.
Thank you for that.
Mike, you've summed that up well. If I can just add, sorry, they've got an alarm going, ambulance on my back. We've also been working with the CSU in terms of capacity, because we have noticed over recent months we've had some issues with capacity on the phone lines. So wherever we've identified a problem, we've contacted the service to try and increase and work with that to work through the problems and find solutions. And we've also, the other thing that we did last year was we did an identical survey to all patients as the national survey, and our scores were much improved when we surveyed all patients in terms of their of the national comparison.
Thanks.
Okay, so just to clarify for me, what you're saying is that the system in terms of ringing up for an appointment hasn't changed and won't change. It's always been like that. Yeah. What's changed is you can't then go and see a doctor. You can't go and see it. You wouldn't be offered an appointment at Sandyway were it to close, or you can't go and stand in front of the receptionist and Sandyway and sort your appointment out. That's the difference.
Yeah, exactly right.
Thanks. John, you had a question.
Yeah, I just want to, let me just roll back a little bit on the conversation there about these surveys. You'll have seen that in Appendix K that we did a review of the engagement sessions that were carried out in the recent engagement. And Dr. Mullin has relied quite heavily on those for his input and discussion today. Our view is that the number of patients percent-wise who were actually involved in that engagement session was less than a couple of percent. The GP national survey that we were just discussing and saying was probably not too relevant, had something like 800,000 responses to 2.5 million questionnaires sent out, so a 30% response. So I think let's try and be consistent here. That if we're going to say that surveys are not really that good, then let's make sure we've got the same, we're working off the same basis. A survey of less than 5% is a lot worse, in my view, than a survey that's 30%, unless for maybe Dainbridge patients didn't engage to the extent that the national population did. So that could be the situation. But I just think we need to be a little bit you know, we're a bit flip about getting old surveys to only tell you what you ask and people don't respond. They do respond if they're asked.
I think in terms of service, I've spent a lot of my time with patient participation groups debating whether or not they're significant and whether or not they're not. And a lot of patient participation groups have chosen to do their own, let's catch people at the survey and see what happens. But yes, I take your point, John. Has anybody got any more questions? I've got some. Oh, Paula's just about to go like that. Paula.
Thank you, Pam. I was just about to type in the chat box to say my name, but you spotted my hand, so thank you. It's been really helpful actually to listen to everybody's thoughtful contributions, and I found it really helpful. So thank you. I think listening to the spirit in which information is described is as helpful as the words on the page. So thank you. One of the things that I just wanted to talk to the surgery about was an area where there seems to be some stark disagreement. I think based on everything I've listened to is the point around patients not feeling engaged or believing the contention around the financial aspect of it. I think that was a point very firmly and clearly made. And I just wondered if the surgery had an answer to that, because I think I heard two different perspectives offered today. It's probably one of the most stark different perspectives that I heard today.
Okay, I'll take that. Thank you, Paula. Finances, to my recollection, was first raised by myself at the last committee meeting. And it was something which has been discussed within the practice for some time, and I will try again to explain what the issues are. But it was something that, you know, you sometimes, I think, as a practitioner, you're fearful of raising the issue of finances, for fear of being labelled a profiteer and trying to wring the NHS dry, so to speak. As GPs, you know, none of us are in that game. There's plenty of other jobs that can be done for a lot more money, but you know, we are well paid, and we enjoy our job. In terms of the financial arguments, you know, I'm not a liar, and I'm not telling lies. And short of opening up the accounts, which I think my partners will be unhappy with, all I can do is say that it isn't the decision or the request, application to close the practice isn't being driven by the current financial situation in the practice. So we have a healthy balance. We are not millionaires. We are congratulated by our accountants year on year for being sensible and efficient with our spending. We want value for money, just like the British taxpayer wants value for money. Undoubtedly, there is absolutely and categorically no connection between the retirement of Dr. Nigel Matthews and the application to close Sandyway surgery. The finances involved are just not that great for an outgoing partner such as Nigel Matthews, and I think that's who the reference is to. Perhaps I shouldn't have named him by name, but I'm sure he wouldn't mind. In terms of the current partnership, two senior partners are retiring. Again, it has no, the application to close the practice has absolutely no connection to that whatsoever. Retiring partners will take some money out of the practice, but these are not massive sums, and it's actually their own money which they've invested for cash flow within the business. So when a partner retires, that money is actually theirs. It may cause a short-term issue with cash flow, but it is not going to be affected in any way by the closure of Sandyway surgery. This isn't a financial decision based upon current finances. It's about wanting value for money in the future and the massive investment which we would have to pay for redeveloping the Sandyway surgery. I hope that answers the question as honestly as I can.
Thank you.
Okay, Paula. Yeah, you're all right with that, Paula? Yes.
Yes, sir.
Thank you. Nobody's indicated that they want to speak. So can I just ask some questions? Firstly, in terms of the use of Sandyway since last November, at the time in November, it was just open for consultations with very vulnerable patients. Is that still the same? Has that remained the same throughout?
Mandy, I'm going to have to pass that one to you, because I sometimes don't quite up to speed with the changes that have. It's such a rapid moving landscape. But Mandy, you'll just have to remind me. I don't think it is.
No, I don't think it is now. So we kept it as a clinically vulnerable site. However, we are unable to open the site up because we can't deliver a safe COVID working or space for patients to visit. So it's still by a triage first, and if there's an appointment, somebody needs an appointment, they can go there. And if somebody's clinically vulnerable, they use a different room than consulting room than if a normal. If any other patients attend.
Okay, so since last November, how have you dealt with things like samples and the things that we talked about before? Have they all had to go through Danebridge?
Yes.
Yeah.
So no one's been able to drop anything off sample-wise or go to an appointment at Sandyway building?
Or at Kingsmead during that period.
Thank you, thank you. And the other one for me, there were some issues that people have already raised in terms of the patient survey and also harm and complaints. But you had some issues about recruitment last time. Have you mentioned the budget for recruitment? Have you managed to recruit to those GP posts, or are you still very dependent on locums, as John talked about?
So thanks, Pam. Actually, we have been successful in recruiting. We have managed to recruit 3 salaried GPs at 6 sessions each. 2 of them have been through an agency, cost of that approximately £11,000–12,000 each. The other one not. They haven't started as yet. I am not quite sure where we're up to in the process of them starting work, but they've all accepted the job, which is the most important thing. And I think we're just going through the process of references, etc. We may even be beyond that point. Mandy will enlighten me there, but yes is the answer. We have been successful, thankfully.
And Mike, they're starting in a phased approach. So I think there's one starting next month and then another one in September. They're doing the pre-employment checks.
Thank you for that. Chris, you've got a question, I think.
It wasn't related to that point, Pam. So do you want to finish yours first and then I'll come in? You're on a roll.
I've got them on. No, it's all right. I've got my next one was of officers, really. I just want to know about our contractual obligations. So maybe you can answer that for me, Chris, and then I'll take your question. I'm just wanting to know. Obviously, the surgery at Sandyway is not offering the full service that we would expect. But actually, the contract expects us, Danebridge, to provide it and isn't specific about what should be provided where, is it? What I'm trying to say to you is, if we allowed for if we said, no, we're not allowing the closure, it could still mean that the surgery doesn't offer the full level of service that we would expect at Sandyway because it offers it somewhere else. That's probably not been said very articulately, but do you know what I mean?
Sorry, there was a noise when I don't know if somebody needs to mute. I can hear a noise in the background. So yes, Pam, that's correct. So the practice have already said that they can provide a level at Sandyway up to a point, but after that, patients need to go to one of the other 2 sites to have the full range of general medical services. So in effect, yes, that would continue. But you've already heard Mandy and others say that under current COVID guidance, they aren't able to do much there because it isn't conducive to COVID operation, and that's not likely to change. What they have said, and as which brings on to our next point, is if you have a practice that's looking to consolidate, shall we say, a better service overall on 2 sites than stretching itself over 3, then I think that is something that the committee need to seriously consider, because clearly that shows that they're looking at how they provide a service. And if a practice does approach the CCG and it's got a branch surgery, the first thing you will say is, are you able to look at just staffing the main for the time being until you sort your model out? So I think it's a good thing that the practices are looking at that. And they've also said, and I'll make the point again, that there is much more scope for that at Kingsmead than Sandyway. And obviously GPs and clinical staff don't grow on trees. And I think the doctors have made a fair point that it is much more appealing to be working over 2 sites than expecting GPs to travel and other staff across 3. We can't grow these staff on trees, and it is a seller's market. So we do need to consider that when you are making a decision. I think that it is reasonable to expect a practice to look at their sites as part of a model. And in my view, the practice have made a good case for consolidating over the 2 sites. Obviously, I'm a member of the committee, but not a voting member, but I am one of the officers that's involved in the operations of the practice.
Very much, Chris. John, you've got another quick question.
Yeah, just very quickly, it's for Mike really. The facts that I gave in my presentation were from a letter that was written to Edward Timpson in July by the practice about locums and GPs and full-time equivalents. Are those facts not correct?
I'm sorry, John, just repeat your question, please.
Yeah, in my when I was talking about the dependence on locums. I was talking about the full-time equivalents being 10 out of 19 GPs on your list. That data all came from a letter that was sent by the practice to Edward Timpson. What you are indicating there is that you're not relying on locums. I just wanted to get my facts straight, if you don't mind.
Yes, thanks, John. I understand. We have, I think we're in a state of flux at the minute. We have been very heavily reliant on locums historically over this last, it kind of ebbs and flows. Approximately 2 years ago, throughout the summer, I think in 1 year we spent, within the last 3-4 years, we spent £140,000 on locum fees alone. It was an extraordinary year. We were very low on doctors and it was very difficult for us. Locums, I would not describe us now as heavily reliant on locums most of the time. We are heavily reliant on locums at certain hotspots, certain times of the month, certain holiday periods. For instance, throughout the whole of the summer, we have got locums coming in on a daily basis. I guess it's your definition of heavily reliant. We're a big practice, but certainly the vast majority of the clinical care which is being offered is from the salaried GPs and the partners. But we do rely upon locums, and they are an integral part of our service, because once we look at our appointments on a weekly basis and we look at it a month, 6 weeks in advance, and when we recognise that we're getting to days or weeks below certain thresholds, we look and seek to employ locums. The locum market also, as a phrase Chris and I have both used, it's also a seller's market, and they can be difficult to get hold of and they can be extraordinarily pricey. So a model is much better, much more stable if you've got salaried doctors who are moving into the partnership with time. In terms of the whole term equivalent, so current numbers are, we have the new doctors I've described apart, we have 19 doctors, GPs who are working at the practice, and that equates to around 10 whole-time equivalents. Partners are often working just less than full-time, but not necessarily in a clinical role face-to-face with patients. So historically, for instance, doctors, partners are working with the PCN for a couple of sessions a week. It's work which has taken them out of clinical face-to-face clinical practice, but they are still working, 6 sessions a week, for example. Training doctors won't have face-to-face sessions for some of their sessions. Dr. Perry does minor ops, etc. So it's not all face-to-face appointments, bums on seats, as it were, but these doctors, these partners are working, in most cases, just less than full-time.
Thanks for that. You might just check that letter that went to Edward Timpson in July, a couple of weeks ago, or a week ago, because it doesn't sound quite what you're describing, but I'll let you have a look at that.
Thanks for that. I'm conscious of the fact there are some people who haven't come in yet, and I just wondered whether Simon, I'd have to ask you, because I know the LMC have put some comments into the report, but you're also a GP, and I just wondered whether you'd got any comments you wanted to make.
Thanks, Pam. So obviously William's been the main input from the LMC on this particular issue, and you've received his sort of thoughts in the report email that he sent through. And I think predominantly it focuses on the difficulty in development of the site at Sandyway and the better premises that are available at the other surgery. And the difficulty going forward in terms of trying to develop the Sandyway premises into something that looks anything like acceptable in the modern day. I think Paula had put in a reasonable question the other day, which was, if the surgery is not allowed to close, what are the opportunities to develop the surgery? I think I know the answer to this, but it is probably worth rehearsing it again, just so that we all know what's likely to happen if it remains open.
I suppose I could try to answer that, or Neil. I mean, the first part of the meeting, we actually approved a system of scoring the estates in terms of our practices. And I know from previous primary care commissioning committees that we've got estates where there's a dire need for some alteration or a new building that would, in my opinion, would take priority over Sandyway. Neil, I don't know whether you want to come in on that.
Yeah. So the question was, can the CCG afford to invest large amounts of money in Sandyway? I guess is the question. As Pam says, we've just earlier approved an investment policy, which is about prioritising. We know we have already in the pipeline some fairly large-scale developments on sites for fairly large populations where the distance to any alternative will be significantly greater, as in many miles, if those sites had to close, and they are in conditions where they may well have to close, either because of the state of the build or because existing leases are due to end. So I think you know the answer to the questions, Simon, that you asked, which is the CCG financially is already struggling to balance how we would deal with the existing pipeline without adding more schemes into it. And I guess the consequence, which people might not understand, is the CCG doesn't have a estates budget as such. So every time we invest in estates, it means we have to cut services. So there is a consequence to any investment decision, which means we have a nice improvement in the building, but we potentially have less services to run out of buildings, which is an inherent challenge for a commissioning organisation.
Thanks, Neil. Louise, do you want to say anything?
Thanks, Pam. Really, it's just to reiterate what I've said in previous meetings regarding this. In total now, we've had 242 comments, representations that have come in speaking against the closure. Obviously, these have been shared and we've let people know that these are coming in. There is clearly a huge, strong feeling from the community, and there remains a strong feeling from the community. It's been really interesting to hear some of the responses today. And for us, I think it's highly unusual for us to get that many comments, as you would imagine, for one particular surgery. So I don't really think I have anything else to add that I haven't previously inputted into the committees to get us to this point.
Thanks very much. And Sarah, have you got anything you want to add from NHSE's perspective?
I could work out then. No, I've not been involved in this process so far. So obviously my input for the meeting today is just to make sure the due process has been followed, NHSEI guidelines. I think because we work across Cheshire and Merseyside, I completely agree with what Chris said about practices need to look forward. They need to be able to consolidate and give quality services to their patients. So there's nothing else I would add to that. Apart from what Chris said, I think that was absolutely spot on. We're in a very different world now. We're in a very different primary care world now.
Thanks, Sarah. Okay, so I'm going to try and pull this to some sort of a conclusion, if people might. What I'm going to do is read out a statement which is about where we're at now. And basically it says, following consideration and assessment of all the evidence provided to the committee by the practice, the CCG and other stakeholders, and if the committee members believe they've had sufficient information to enable them to make an informed decision, the Primary Care General Practice Commissioning Committee is asked to decide whether to refuse or agree the application by Danebridge Medical Practice to close their branch surgery at Sandyway, in line with the national GMS contract held by the practice and under the process outlined in the Primary Care Policy and Guidance Manual, which governs the management of said contract. So basically, I'm going to go around to the voting members of the committee and ask them their views, please. And it's really awful, it's having to pick one person first. But you know, I haven't heard from Dan today. So Dan, I'm going to put you on the spot first, please.
Thanks, Pam. That's me for moving, just as you're saying, you find somebody. That's absolutely fine. Listen, it's been a really, really interesting conversation. Obviously, the reading beforehand was very helpful. These are always very difficult conversations and very difficult decisions. You know, we've got to weigh up the impact on the individual residents in the region, in the area, versus the sort of general challenges that we're seeing in terms of estates and sort of moving forward in terms of, you know, how primary care is going to be working. I suppose the fundamental thing that I'm thinking is my anxiety about keeping it open, from what I've been hearing around the contractual situation, all the rest of it is it will just be run as a shell anyway. I don't think that there's any requirement that full service would be out there anyway. So my sort of decision would be to approve it, albeit with, you know, a deep understanding of the impact that's going to have on the local residents. But I think under the circumstances, that's my decision.
Andrew.
Thanks, Pam. Yeah, similar to echo the comments of Dan. Dan, really. I think obviously where we've been over the last 18 months with COVID, it has changed the way that services are delivered or can be delivered, and I think obviously Mike's mentioned that in the during his monologue earlier. I think again, I think keeping the site open and the dilapidation that will have occurred over the past 12 months or whatever, and also the amount of work that may need to be done to make it fit for purpose. So again, for me, I think regrettably, I think I would vote to close the surgery.
Neil.
Yeah, I've obviously spent 7 or 8 months thinking about this, if not more now, and I must admit my positions probably has moved as I've seen and the increasing pressure that general practice is facing and the workforce constraints, and I can fully understand that the desire of the local community to have a local building, but I must confess that I'm now of the mind that to make Danebridge as a surgery work most effectively, trying to run it across 3 sites, I think is stretching it too far. And that links back to some of my earlier questions around improvements and opportunities to learn from some of the patient feedback. I think there is something, so I am saying that I would agree with what's been said earlier about agreeing the application to close. I think there probably is some further work around some of the outputs, assuming that others don't disagree and it ends not being that decision. There needs to be some further work on some of the outputs of those sessions in terms of what would be called a close down plan, in terms of making sure that some of the things that the practice has committed to are delivered. Because I recognise that patients are losing something, even if they're losing something that is never going to be quite the same as it was several years ago, because medical practice and workforce constraints have prevented that being the case.
Thank you, Neil. Wendy.
Yes, my position has moved too. I think the emphasis on improved quality of care that we were hearing from Mike, and also to try to ensure that patients get safe treatment, that has definitely swayed my opinion today. And I think that given the current circumstances at Sandyway, it would be very difficult to match or replicate the sort of safety and quality of care that Danebridge can offer. I think had we not had COVID and that it had shut down completely anyway during this period, there has almost been a trial run for Sandyway residents to see what it's like without a surgery to attend. And I think given more perhaps investment by Danebridge in ensuring that patients' accessibility is high, that people are not disenfranchised by the technology, because it is tricky for elderly patients. But I think that there is a very high awareness of that. So like Neil's saying, a bit more assurance on the close down plan, that actually all these things are taken into account for patients to attend surgery when and as they need to. I will support the closure.
Finally, Paula.
Thank you. I've heard a lot of information that shows a huge passion and commitment from the local community in terms of their feelings about this practice, and I think we have to pay testimony to that today. I think we've heard a very considered position, and I think we've heard a lot of evidence about the effort that the community have gone to make sure that their views are heard. And on that basis, I recognise that my decision to support the closure will be a huge disappointment to the population. And my decision is based on this issue of the longevity of the premises to deliver a primary care model and practice that has become more commonplace over the last 12 months, and which will be expanded further in terms of the other roles to supplement not a general practice doctor-led model, but to provide clinical interventions for a range of other staff as well. And that's not a local position, that's the national position in terms of the changes that's coming for primary care, some of which we've experienced over the last 12 months driven by COVID, but there is also as well a national direction of travel in how we work with communities to support people in a situation that is moved back from hospital-based services.
Thank you, Paula. So I'm the only person left as a voting member of the committee. I have to say personally, I found this one of the most difficult decisions that I've had to make. And I've been in public service for a long time. It's also been one of the most difficult things I've had to do as a chair as well, because I've swung over the last year one way and the other way and one way and the other way. But I think today I concur with what my colleagues on the committee have said, partly because I think that given the new way that primary care is going to be delivered, whatever happens to Sandyway, it could never be brought up to the standard that we really need for our patients in that part of the world. I understand fully that there will be some patients that find that they're disadvantaged, especially older patients that can't get to the surgery in Danebridge or Kingsmead. But I was reassured by what Mike Mullen had said in terms of the fact that they were prepared to use their staff to go out and see those patients, which you actually think that probably means they get a better service than they would have done at Sandyway anyway. So I too believe that the application should be approved. What I would say though is, given that we've now got a unanimous decision of the committee, and I thank you all for it because we've had a lot of work. I thank John because he's done a tremendous amount of work with the community. What I would ask is that the surgery doesn't close Sandyway branch for at least 90 days. That's as a minimum, but that actually we work, Chris, I'm charging you with this, we work with the surgery on a plan, that the plan seeks to improve what we've heard has started already, and that also that the plan involves the patients right across the board, not just at Sandyway, in whatever improvements they're going to make, but particularly with those patients of Sandyway, because I think there have been some difficulties with involvement and engagement, and it would be remiss of us not to. I'm satisfied that what happened has happened, and it hasn't made a difference to my decision. But I think going forward, I would really like to see continued engagement with patients about improvements to the practice, and whether or not you use your PPG or whether or not you, I don't know how you need to do it, but I think that's something that I'd like to see as part of the plan. So is there anything else that I have missed out in terms of my conclusions? Chris, have I covered everything?
I think you have. You've summarised the decision, and no less than 90 days for the closure, and we'll obviously follow all that up with the appropriate paperwork with the practice. But yes, I think you've covered everything.
I think I'd quite like for that plan to come back to the committee.
Absolutely, of course.
Possible. So we can have a view on that and see how things have progressed. Okay.
No problem.
We actually managed to finish on time, which I didn't think we would, but thank you. Oh, Paula, have you got something you want to say?
Can I speak, please? Obviously, I'm very new to all this, but I would hope that part of the plan is that the surgery have to work out, you know, how that the pensioner who can't access the car and who doesn't have family is actually going to get to the surgery, because the thing that I've picked up listening is that we've heard lots of reasons, but I felt that actually those very vulnerable patients haven't really been given due consideration, and I hope they will be given due consideration when you look at this plan going forward. Thank you.
I think Dr. Mullen did make mention of the paramedic going out to look at some patients that couldn't come down to the surgery that needed to. And I'm pretty sure that I'm right in saying that that would be something in your ongoing plan. You would continue to look at services like that. Is that okay? Yes. Has anybody else got anything they want to say? No? Okay. Well, thank you, everybody. Thank you for your input. Thank you for your time, especially on such a warm day. I shall call the meeting to a close now, and our next meeting of the Primary Care Commissioning Committee is sometime, and I can't remember it. I think it's in October, but I look forward to seeing you all there. Thank you very much, everybody.
Thank you.
Thank you.